for inviting me to this August gathering of Biomarkers 2015. So as we are already running after the schedule, behind the schedule, so I will complete my talk before the scheduled time. Primarily, I am a clinician, physician of internal medicine specialty. I am not a biochemist. So my focus will be on my talk regarding the clinical application of troponins as cardiac biomarkers in various cardiac conditions. So what is a biomarker? Now, in today's morning session, Dr. Moses gave a test upon the biomarker, its special characteristics. So to add further, what is a biomarker? It is a substance which is used as an indicator of a biological state, and it is objectively measured, and it is evaluated as an indicator of normal biological processes, pathological processes, pharmacological responses to a therapeutic intervention. So as my topic is cardiac biomarkers, so what are cardiac biomarkers? They are substances released from heart muscle whenever it is damaged. So what should be an ideal cardiac marker? So ideal cardiac biomarker must have cardiac specificity, high cardiac specificity. It should help in the easy diagnosis, and it should play a designed role in the management of clinical subject. It should be reproducible, and it should be easy to interpret, and it must be accurate, and it should be applied at the right time. So what are the markers of myocardial necrosis? They are myoglobin, creatinine kinase, especially MB type, and troponins. So what is creatinine kinase? Now creatinine phosphokinase, it is an enzyme found mainly in the heart, brain, and skeletal muscle, which catalyzes the conversion of creatinine to phosphocreatinine. Those CPK enzyme consists of two subunits, B type, that is brain type, M type, that is muscle type, and it makes three different isoenzymes, that is CPK BB, CPK MM, CPK MB. So skeletal muscle primarily has CPK MM 98% and CPK MB 1 to 2%, while the myocardium has CPK MM 70% and CPK MB fraction 30%. So CPK MB, it has high specificity for cardiac tissue, and it starts rising 4 to 6 hours after the onset of infarction, and the peak levels are achieved in 12 hours, and they return to baseline within 36 to 48 hours. And it helps to identify reinfarction if level normalizes and rises again. But false positive elevation in the CPK-MB levels have been found in various conditions. For example, whenever there is significant skeletal muscle injury and cardiac injuries other than myocardial infarction, for example, blunt chest trauma and patient suffering and defibrillation, use of defibrillators, and use of cocaine abuse. So, with this limitation, there is a search for cardiac specificity continues. So cardiac troponins, they are primarily cardiac regulatory proteins which control the calcium-mediated interaction between actin and myosin. So three types of troponin exist, that is troponin I, troponin T, and troponin C. Each subunit has a unique function, that is troponin T binds the troponin components to tropomyosin, while the troponin I inhibits the interaction of myosin with actin, while the troponin C contains the binding sites for calcium, which helps in the initiation of contraction. So these are the slides which show that there are three troponins, cardiac troponin, troponin T, C, and I, attached to the basal filaments and molecules. This is again slide showing troponin T, I, and C binding to the actin and tropomyosin. So troponin C is not useful for diagnosing cardiac injury because the cardiac isoform is shared by skeletal muscle. So basically, in the clinical practice, we are using troponin T and troponin I. So multiple cardiac troponin T isoforms are expressed in the human heart, that is predominantly cardiac troponin T3, while troponin C and troponin I are expressed as single isoform. This is the main advantage of this. So there are substantial differences between the amino acid sequences of the cardiac isoform troponin I and troponin T and other isoforms, and it has been possible to produce highly specific monoclonal antibodies without cross-reactivity with other non-cardiac forms. So what is troponin I? Troponin I is a cardiac muscle protein with a molecular weight of 24 kilodaltons. It has additional amino acid residue in its N-terminal, which does not exist on the skeletal form. And it has a half-life of 2 to 4 hours, and the serum levels start rising within 2 to 8 hours. While on the other hand, troponin T, cardiac troponin T, it is present in fetal skeletal muscle and it is absent in healthy adult skeletal muscle. The gene for cardiac troponin T may be re-expressed in skeletal muscle disease. So the biological half-life and serum levels start increasing times. They are similar to troponin I, that is 2 to 8 hours or 4 to 8 hours. So troponin release in cardiac injury, what happens? It is proposed that there is a small cytosolic pool and a larger muscular pool of troponins. So there are two pools. During cardiac injury, depending upon the severity, troponins are released from both the pools. An initial small elevation occurs when troponins are released from the cytosolic pool, while the troponin molecules in the cytosol of cardiac muscle, they diffuse across the sarcolemma and they pass onto the surrounding lymphatics and blood vessels. Thereby they are detectable in the blood. So if the injury continues and necrosis progresses further, so there is a release of further troponins from the muscular pool, not from the cytosolic pool. So what is the pattern of rise and fall? When measured with older generation assays, so the troponin levels can be detected 4 to 12 hours after onset of myocardial injury, and the peak levels reach about 12 to 24 hours. Then there is a gradual decline over several days that happens 7 to 10 days in the troponin I and 10 to 14 days for troponin T level. So continuing breakdown of myofibrillator bound complex explains the prolonged elevation of both troponins for up to 10 days after infarction. So it means that the levels remain elevated even 7 to 10 days or 10 to 14 days after the infarction has occurred. So this accounts for the increased detection of cardiac events using troponin and its increased sensitivity, but make the diagnosis of reinfarction more difficult. So we cannot assess whether the reinfarction has occurred because the previous levels do indicate that the levels were for the previous cardiac event. So this is a slide showing the cardiac troponin release after myocardial infarction from the sarcolemma, and they are released into the blood, binding to the actin and myosin. So what happens in this is the second slide. So the levels start increasing. They remain elevated for 12 to 24 hours, and they start falling, and that level does not rise to the basic level also. So what is reversible versus irreversible injury? Now reversible ischemia after exercise stress testing in humans has not resulted in cardiac troponin elevation. However, many studies have suggested that troponin I can be released in reversible ischemia. For example, it can be shown by Feng et al. That in a porcine model of ischemic heart disease, reversible ischemia has been found to be associated with cardiac troponin I. So in this case, the source of troponin is hypothesized to be from the free cytosolic pool leaking through a reversibly damaged myocyte membrane. So this hypothesis has been further substantiated, supported by clinical observations of true protein release patterns in patients with unstable angina. That is an early transient pattern and a persistent pattern. So two patterns have been recognized in a transient reversible ischemia in a patient of cardiac event suffering from acute coronary syndrome or myocardial infarction. So regarding the troponin assays, so what is the collection and panels? The troponin sample assay relies on serum levels of troponin. The sample collected is whole blood through venipuncture. So there is no special patient preparation is required, and the patient does not need to be fasting also. Blood for the test can be drawn at any time of the day. It is not specific for any time. Generally, troponin T requires sample collection in the heparinized test tubes, that is green top, while the EDTA or heparinized tubes are used for troponin I. So this is the major difference. Most specimens require centrifugation prior to running the test in order to separate the serum from the cellular component. But in general, the troponin T, the blood sample should not be frozen or refrigerated immediately, and it can be stored at room temperature for up to 8 hours for analysis after taking the sample from the patient. So the troponin levels, they are determined using ELISA method. But the difference in amino acid sequences from skeletal muscle and the cardiac troponin I and T has allowed production of antibodies specific for cardiac troponin in these assays. So further assays are available, that is the latest one, that is rapid advance in amino acid technologies, and the international adoption of traceable troponin calibration standards have allowed manufacturers to develop and calibrate troponin assays with unprecedented analytical sensitivity and precision. So a contemporary cardiac troponin I assay such as troponin I ultra detects plasma cardiac troponin levels as low as 0.006 nanogram per ml. But the usual level, normal levels of troponins are up to 1 nanogram per ml. So with this method, we can assay range that spans 4 orders of magnitude, that is ranging from 0.006 to 50 nanogram per ml. So the limit for detection of a contemporary cardiac troponin T assay is as low as 0.005 nanogram per ml. So it can be up to 50 nanogram per ml as already described. So in the year 1995 and 2007, the limit for detection fell from 0.5 nanogram per ml for some cardiac troponin assays to 0.006 nanogram per ml for troponin I ultra, and that is 100-fold improvement in analytical sensitivity. So this is a slide showing a patient having acute coronary syndrome subjected to a cardiac troponin T and I levels in the year 1995 to 2007. Remarkably, the use of contemporary high-sensitivity cardiac troponin assays makes it possible to detect low levels of cardiac troponin even in plasma from healthy subjects. Indeed, high-sensitivity cardiac troponin assays are designated as such on the basis of their ability to detect cardiac troponins even in healthy individuals. But the latest generation of high-sensitivity cardiac troponin assays can detect cardiac troponin in 95% of a reference population. So the ability to detect cardiac troponin in healthy individuals made it essential to define a clinical decision limit for cardiac troponin concentration that a positive cardiac troponin can result. So the national, what is a positive troponin result? So there is a rule of 99th percentile rule. So the National Academy of Clinical Biochemistry issued a guideline in the year 2007 that stated that in the presence of clinical history suggestive of acute coronary syndrome, that a patient presenting with chest pain with ECG suggestive of ST elevation and T wave inversion. So the following is considered indicative of myocardial necrosis consistent with myocardial infarction in the form that maximum concentration of cardiac troponin exceeding 99th percentile of values, that is coefficient of variation less than 10% for a reference control group on at least one occasion during the first 24 hours after a clinical event. That is when the patient has been diagnosed with acute coronary syndrome, and we have taken the sample and subjected for evaluation with reference to cardiac troponin T and I, that this 99th percentile rule, that is the coefficient of variation less than 10% in that first clinical event. So this guideline provides the framework for determining the decision limit or a positive troponin result. So based on the 99th percentile rule, troponin decision limits of several high sensitivity cardiac troponin assays can be set as low as 0.01 nanogram per ml. Initially, we have described 0.005 to 0.006 up to 50 nanogram per ml. So this makes it possible to identify patients with acute coronary syndrome earlier. So what I mean to say, these ultra-modern assays for the detection of cardiac troponins, though they make earlier coronary, they make the patient, they make the laboratories to diagnose the condition earlier so that the coronary intervention can be employed for the sake of the patient to save their lives. However, while improving clinical sensitivity for the diagnosis of myocardial infarction, the increased analytical sensitivity has come at the cost of reduced specificity. thus presenting an additional diagnostic challenge for the clinician, because these cardiac troponins may not be, they are although highly sensitive, but may not be, they are less specific. So again, this slide shows the use of high sensitivity assays to detect the levels as low as 0.04 nanogram per ml in the year 2007 as regarding the 99th percentile rule with regard to National Academy. So these levels start rising within 2 to 8 hours, and the levels reach about 12 to 24 hours, and they remain elevated for 4 to 8 days, or 8 to 10 or 14 days even after the first cardiac event. So the cardiac troponin levels in a healthy reference population and in an acute coronary syndrome population. So this slide was showing the frequency histograms of real troponin I levels in healthy reference controls, along with the distribution of the same troponin levels as measured with a less cardiac troponin I level. So what is the specificity of a troponin test for a patient suffering from acute coronary syndrome? So with the use of the 99th percentile cutoff for cardiac troponin positivity, it does not mean that 1% of the population still suffering from the myocardial damage. Rather, this cutoff is useful only when applied to patients with a high pre-test probability of acute coronary syndrome, diagnosed clinically on the clinical suspicion, supported by ECG and additional biochemical investigation in the form of cardiac troponin T and I estimation. So positive troponin in the setting of a low pre-test probability for acute coronary syndrome may be suggestive, but clearly it is not indicative of a coronary event. Traditional wisdom before the advent of high sensitivity cardiac troponin assays, it was held that troponins do not appear in the circulation of individuals with a healthy myocardium. So these levels used to be considered indicator of myocardial necrosis. However, with high sensitivity troponin assays which are available now, the circulating cardiac troponin T and troponin I levels can be found in the plasma or serum as a result of transient ischemic or inflammatory myocardial injury with reference to reversible or irreversible myocardial injury. And other important situation is these cardiac troponin levels may be detected in conditions other than the acute coronary syndrome, we must be aware of these conditions. For example, there are cardiac conditions like cardiac contusion resulting from trauma, use of cardioversion, acute and chronic heart failure by taking endomyocardial biopsy, patients suffering from aortic dissection, and HOCM, tachyarrhythmia and bradyarrhythmia, and apical ballooning syndrome, post-percutaneous coronary intervention, and rhabdomyolysis with myocyte necrosis, patients suffering from myocarditis, pericarditis, or endocarditis. And there are non-cardiac causes also in which the cardiac troponin levels may be raised. And these are pulmonary embolism, severe pulmonary hypertension, renal failure, stroke, subarachnoid hemorrhage, sepsis, burns, critical illness, extreme exertion. So there is a need for serial troponin testing. In addition to the absolute level of cardiac troponin in plasma or serum above the decision limit, a critical component of the diagnosis of acute coronary syndrome is cardiac troponin kinetics. Although absolute cardiac troponin elevations are seen in multiple chronic cardiac and non-cardiac conditions which I have described above, while the rise and fall in serial cardiac troponin levels strongly supports an acutely evolving cardiac injuries such as most commonly acute myocardial infarction. So the serial estimations are must in a patient suspected of acute coronary syndrome to properly diagnose and treat the patient for the risk stratification and management. So serial cardiac troponin testing is a help establish final diagnosis in 3 patients in the literature review. So these are the patients suffering from myocarditis, congestive cardiac failure, myocardial infarction. So they were saved. Previously, clinicians often had to wait an average of 6 hours. With the lower sensitivity, lower precision of cardiac troponin assays to see a conclusive increase in plasma cardiac troponin levels after the first troponin measurement. But today's high sensitivity cardiac troponin levels, they are available. So we can detect the cardiac event even 2 to 3 hours after the patient has suffered an attack of acute coronary syndrome. So it is recommended to collect a second specimen for cardiac troponin testing within 2 to 3 hours from the collection of the blood sample at presentation to help confirm the diagnosis. So we can, although the patient is presenting late in the clinical setup, but we must be able to collect the sample 2 to 3 hours after the patient had an experience at chest pain. So they have a great role in the prognosis also. So with myocardial infarction, any troponin level above the reference range, that is above 1 nanogram per ml, is associated with an increased risk of adverse event in both the short-term and long-term studies. In fact, the size of the infarcted area may be predicted based on peak cardiac troponin levels at 72 hours. So to conclude my talk, so the cardiac troponins, they are scientific tools for the diagnosis of acute coronary syndrome, myocardial infarction in patients with unstable angina, for the management risk stratification, so that the patient can be subjected to coronary intervention in the form of percutaneous coronary intervention just to save their lives, but keeping in view the false elevation of these levels in many non-cardiac conditions. So we should be aware of these conditions, keeping interest of the patient. So thank you for patient hearing.